Hey guys, I'm not sure what's going on, but my camera's my camera's not starting. I'm trying to get it to work. Hold on one sec. All right, that was weird. Not sure what happened there. You guys hear me now? You see me? Yeah. Okay. Sorry about that. I don't know what happened. It was just not saying my camera wouldn't start. Okay. All right. So, happy Friday, everybody. Good to see your faces. We're going to go ahead and get started here in just a sec. Wanted to share just a couple brief things with you guys. Number one, let's just take a look at what's going on next week. Okay, let me just point you to a couple things here in Canvas. Number one, we're going to move into the muscle section of the lab starting next week. Okay, and so we will have a synchronous lab next week. And I sent out an update this morning telling you which labs will be synchronous. There'll be 3 more synchronous labs. Those are on the Zoom calendar. I deleted the other ones, and Professor Mahoney deleted the other ones. So there's 3 more. It's pretty much every other week starting next week for 3 weeks. Okay, and so we'll do a little bit of an overview, a little bit of time to study, kind of give you some of my tips on how to study each section of muscles that we're talking about. Okay, one thing that you'll need to do that you can see over here on the left is there's a muscle lab resources module there, and then a page. You see that you can't actually access this page here, this muscle lab resources page, until you go in and do the consent for cadaver videos. Okay, so there's some videos that I created where we use the cadavers, and we're under strict guidelines by the people who decided to donate their bodies and the laws that regulate those. For who can see those cadavers and who can't. And so there's just some ethical things you need to read over and then just agree to, and then it'll allow you to look at that page. Okay, so that's that. And then let's take a look at what we got for the week. Okay, so week 7 is where we'll be next week. Obviously a master in A&P, just like always, due on Monday. And then we'll have we'll have another TBL day, IRAT and TRAT 3 on Friday, and there's no lab quiz next week. Okay, synchronous lab, but no lab quiz. All right, and the video is already posted for the TBL day, and that is our first introduction to learning muscles. Okay, so you're going to learn the hip muscles and the thigh muscles, and then you'll come to class ready to take a quiz on that, as well as work through some activities. Okay. All right, and then obviously if you haven't completed the quiz yet for tonight, make sure you complete that before 11:59 p.m. tonight. Okay, any questions for me?
Just a quick one about the quiz tonight. Which lectures are going to be on there today? Is it going to be Wednesdays and Monday? And then,
Yeah, let's see. You can always just click right on it, and it tells you that. So yeah, the bone classifications in histology and bone development and homeostasis, those 2.
okay, thank you.
Yeah, for sure. Okay, any other questions before we get rolling? Okay. I wanted to share something. As all of you know, there was a tragedy in our community this week. Dr. Ryan Botts passed away, and I know some of you were currently in one of his classes. Some of you have had classes with him in the past, and it was he was one of my very close friends, and it's been a really rough week for the whole campus, but definitely a rough week for me as well. So I just wanted to say a couple things about him. He was he was one of the best men in my life, to be honest. One of the best men that I know, as far as just always present, always had time for you, always available to help, and with whatever you needed. And so we're all going to miss him so much. And yeah, I would just ask you to be praying for the whole situation, because there's so many people impacted by that. And obviously his family and friends, but the whole campus and as well. So yeah, maybe let me just open us up with a word of prayer, and then we'll get started. You can bow your heads with me. Lord, I just thank you for the opportunity to be together today virtually. I thank you for the all the individuals on this Zoom call right now, and thank you for the fact that they were created in your image, and all yeah. And I just pray that we would yeah, those of us that are personally impacted by this loss in our community, that you would walk alongside us, Lord, and that you would give us the strength that we need, but also give us the space that we need to grieve and to mourn, and to go through the processes of the heart that you've created for us to do. And we just pray for his Ryan's family and friends, and all the things that are going on right now, and the challenges, Lord. And we pray that this community could continue to come together and to carry each other through this time. And we pray these things in Jesus' name. Amen. Okay. All right. So behind that picture was the slide that you guys have. That is, usually I just talk a little bit about how something I kind of already talked about in the recorded lecture this week, that the joints of our skeleton are the weakest point of our skeleton, right? But without joints, we wouldn't really be able to move, right? We would just be as stiff as a board, right? But we need those hard bones that muscles can pull on and create levers to move. But we also need places where those bones hinge and where they joint together, right? Or else we wouldn't be able to move at all. And so it's kind of this balance between freedom that the joints provide, and rigidness and stability that the bones provide. It's kind of a cool metaphor for life, and the way that God lets us have freedom, but also gives us some rules that we should try to abide by. And it's kind of the way I think about the joints versus the bones. So we're going to dive into talking about specifically synovial joints today. And hopefully most of you have watched the video on the specific types of joints, or the different types of joints, I mean. And there's a bunch of other ones besides synovial joints, but synovial joints make up the majority of our joints, and they're the ones that we typically think of when we think of a joint. Okay, so let's go ahead and do this question here on your clicker app. Yeah, you know what? Let's not do that question. Yeah, I forgot that was one that kind of was back. I forgot to remove that one. That was one that was back when we used to teach the two types of ossification, and it's kind of it kind of more applies to that. So we don't have to actually get into that one. But let's do this one instead. Number 2 here, the second question. Go ahead and think about that for a second. See if you have any ideas on this. Take a guess if you're not sure. Okay, anybody else? Give you about 5 more seconds to send something in. Okay, looks like we got everybody today, everybody that's here. Good. All right, go ahead and turn that off. All right, so I forced you to choose one, but even though it said all that apply, but the majority of you are putting either B or C. Okay, so what functions of a synovial joint below are provided by the hyaline cartilage? Okay, and so the hyaline cartilage, most of you put B or C, so shock absorption, definitely, right? It's that firm, rigid surface, but it has a little bit of give to it, right? It's also very smooth, right? Smooth surface that gives that nice soft and not soft, but smooth surface for those bones to slide back and forth on. Okay, so that's definitely true, B and C. But then also, so shock absorption, smooth surface. It's also a reservoir for synovial fluid. We haven't talked about that one yet. We will in just a sec. Synovial fluid is a lubricating fluid inside of our joints. There's a little bit of sponginess to hyaline cartilage. And so when you're not moving much, that synovial fluid kind of soaks up into that spongy hyaline cartilage. And when you start moving again, it pushes out and it comes out and it's available to use. Okay, it doesn't hold the joint together because it doesn't span the joint, right? It's on both sides, but it doesn't hold it together. And in a way, it provides blood supply, maybe more nutrient. More accurate would be nutrient supply. There's actually no blood in your joint unless you have damage to your joint, but it does provide nutrient supply kind of via the blood, but there's no blood actually in the joint. So all three of those are correct, A, B, C, and E. Okay. I'm gonna turn this light off behind me real quick. Okay, that's better. All right, so we're gonna talk about each of the components of synovial joints here. And then next class, we'll get into specific synovial joints, talk about the shoulder, the knee and stuff. We'll talk about a little bit about that at the end of today, but more so on Monday. Okay, so synovial fluid, and the reason I have this image here is that I want to Meta World Peace. I don't know who it is actually, Daniel. Does it look like Meta World Peace? yeah. I don't know who that is actually. I just found that image on Google Images because so I used to work for the Chargers when the Chargers were in San Diego. I was an athletic trainer for them for 2 years doing an internship, and a lot of these guys have very damaged joints. Okay, especially knees and hips, and so it's pretty common for them to have their knees drained maybe every month or so during the season, and so one of my cool experiences as a student, the Chargers doctor used to be Point Loma's team doctor as well. And so he would come to campus and we would go to his clinic and do rotations with him. And so when he would, the first time I saw him drain a knee, he told me to put gloves on and he squirted some synovial fluid from the guy that he just drained the knee into my fingers and had me kind of feel it between my fingers. And he was just like, like, what does it feel like? It literally almost feels like engine oil, right? It's a little, not quite as thick as engine oil, but it's super slippery, right? Very slippery type fluid. And so these guys are constantly getting their knees drained, and taking that much fluid out of your knee is a lot, right? But a lot of times they would have a large syringe like that, and they would fill it up multiple times in one shot, and then they leave the needle in and they put another syringe back on with the medication to put in there, some cortisone and some other medication to numb the joint for a while, some other numbing medication. So super common procedure for those guys, unfortunately. So synovial fluid, found where? It's found inside the cavity of the joints, and it's also found in the hyaline cartilage. Like I just said, hyaline cartilage is a reservoir for it. Okay, so what's it made up of? What are the components of it? It's made up of something called hyaluronic acid, and this comes directly from the cells in the synovial membrane, and this is what gives it its viscosity. Okay, so viscosity is that kind of slipperiness, and gives it that lubricating principle, okay, or property. And so it's able to thin with activity is something super interesting about it. So as we warm up, as our joints get warmer, and as that fluid gets warmer, it becomes more thin, and it actually allows your joint to move more rapidly. Okay, so that's one interesting thing about it. We also find phagocytic cells in it, some macrophages floating around, some other immune cells. And so because your blood doesn't have access to your joints, we need some presence of the immune system here and it comes through the synovial fluid. Okay, any questions on that? Besides who this guy is? You guys already figured that out, though, it looked like on the chat, so. Okay, all right. Okay, so synovial fluid, a little bit more about it. Again, it kind of gets soaked up in the hyaline cartilage, okay? And when you start moving your joints, those two bones push together against each other and it squeezes out some of that fluid, okay, by the compression. So the function of this is the fact that we get more of the fluid when we start moving, which is good. So we get more lubrication because when we start moving, we push some of that out. So we got more fluid available for lubrication, okay? And then the cartilage actually stiffens up. The less fluid is in the cartilage, the stiffer it is, okay? So that helps in both ways. It helps to lubricate the joint more by getting the fluid out, but then also makes the hyaline cartilage stiffer so you're less likely to damage it during exercise, okay? And then when you stop exercising, it gets soaked back up. But also this movement in and out of fluid and this compression on your cartilage is exactly what stimulates new production of fluid. Okay? And so exercise is definitely good for your cartilage. Okay, so the application to the warm-up is kind of already there. I think we've talked about it, that if you warm up, you're doing a couple things. You're warming up that fluid, so it becomes a little bit easier to move. And then secondly, you're pushing more fluid in, so you have more lubrication, as well as you're making that cartilage stiffer by getting that all ready before you start exercising. Okay, as we age, as our cartilage degenerates, as we move towards something called osteoarthritis, then the amount of fluid in the joint declines and it dries up. Okay, any other questions about that? Okay, so the components of a synovial joint, number one, we have a joint cavity with the fluid, okay? We have an articular capsule, and the articular capsule is made up of two components, the fibrous capsule, which is this kind of thick layer out here, and then the synovial membrane, which is this kind of bluish layer on the inside of that. It's the internal part of the capsule, okay? And then there's articular cartilage. Articular cartilage is the hyaline cartilage we've talked about. And then lastly, there's different ligaments depending on which joint it is. Okay, we'll talk about each of these components next. Okay, so let's talk about the articular capsule first, and specifically the fibrous part of that. Okay, remember that we talked about this as an example of a location where we found irregular connective tissue, right? Not regular connective tissue, because with irregular connective tissue, we have collagen going in multiple directions, so we can withstand force in multiple directions, not just one. And that's exactly what we need in a joint that can move kind of in many different angles. Okay, so it's mostly made of collagen. Also, this is where blood vessels and nerves are housed, and you can see that. Okay, this joint capsule is just woven right into the periosteum of the bones that it attaches to. So it's just continuous with the fibers of that periosteum. Okay, and then in certain places it can thicken to form ligaments, right? And so there's thickenings of the joint capsule which forms ligaments. Okay, so the function of this is really to hold the joint together. This is a structural component of the joint, holds it together. Okay. All right, so then that second layer of the articular capsule is the synovial membrane. This is made up of mostly areolar connective tissue, okay? And it has a lot of folds within it, okay? So many folds that helps to increase the surface area of the membrane, which allows for more cells to be there, and those cells are what are helping make the fluid, okay? And it lines the whole cavity except for where the cartilage is, and you can see that again with that kind of blue. And this is just a 2D image of the joint, right? Obviously it would be in the front of this and behind this as well if it was 3D. But so it's everywhere lining the joint except for where the cartilage is, okay? And the functions of this is what makes synovial fluid. It filters nutrients and other components out of the blood, pulls that out of the blood, and then adds in hyaluronic acid, and that's what gives it that viscosity. Okay, Questions on that? Ready to move on? Okay, see some of you still writing, but most of you are giving me a head nod. Okay. All right, so another component is the articular cartilage. Okay, we've talked about this already. It's hyaline cartilage with synovial fluid in the matrix. Okay, it's relatively thin in adults. We're only talking about 1 to 2 millimeters. Okay, in kids, we've got a lot more, 5 to 6 millimeters. Okay, this lines the end of all long bones. Okay, the function of it, number one, it's very smooth, so that reduces friction. And then we already talked about how it kind of is a little bit spongy, so that can help absorb shock. Okay, so when you hear of the term somebody has arthritis, it usually means that their articular cartilage is degenerated. Okay, that's a general term for just joint inflammation. That's another good suffix to know. Itis just means inflammation, and then arth means joint, right? So it's just joint inflammation. Okay, but specifically, this would be called osteoarthritis. Okay, there's multiple types of arthritis, so we'll talk about next time. But osteoarthritis is when the hyaline cartilage breaks down. Okay. All right, so let's talk about ligaments a little bit. So ligaments are these thick collagen bundles. Okay, very strong, band-like. Okay, and there's really 3 different types of ligaments that are in the body. Okay, there's capsular ligaments. Capsular ligaments are really a part of the capsule, but they're just thicker parts of it, thickenings in the fibrous capsule. Okay, some examples of those would be the popliteal ligaments. You don't have to know the popliteal ligaments, but they're in the posterior part of the knee. Okay, you can see those right here. So this is a posterior view of the knee. Popliteal ligaments are really just kind of thickenings right here of the normal joint capsule. Give it some stability to not hyperextend your knee. Okay, then we have extracapsular ligaments. Extracapsular ligaments are completely separate from the joint capsule itself. Good examples of these in the knee would be the collateral ligaments. Okay, so there's the MCL and the LCL, right? The medial collateral ligament, lateral collateral ligament. Okay, has anybody torn their MCL? You got one there at least. Yeah, it's a somewhat common sprain to have in the knee. Okay, those are right here. So lateral collateral and medial collateral. Okay, and then we have intracapsular ligaments. These are just completely inside the joint. They're not even touching the joint capsule at all. They're fully on the inside. Okay, and a good example of these in the knee would be the cruciate ligaments. So the ACL right there and the PCL. Okay, put your hand up and leave it up if you've torn your ACL. Okay. One, Brett had the same. They went twice for Alejandro. Okay. Anybody else? Is that all we got? I'm surprised. Maddie, you never did soccer? Do you play soccer?
No.
Yeah.
My problem, I dislocated my kneecaps 6 times.
Ouch.
No ACL.
Wow. That's brutal. That's painful. That might be more painful than an ACL. Yeah, no fun. Okay. Well, yeah, we'll talk about those ligaments that you tore later, next class, but not these ones. Yeah, so those are just the 3 categories of ligaments and some different examples of each. Okay, so what are the functions of ligaments? They're literally to limit motion. Okay, they each have a specific motion that they limit. Okay, so the ACL, the ACL we'll talk more about next time. It's a little bit more complicated what that one limits. But the MCL is pretty simple. And the MCL limits your knee from bowing in, right? So picture somebody kicking you in the side and the outside of the knee and your knee going in, right? That's what the MCL is fighting against, okay? And that's how you would tear your MCL if that happened, okay? So it gives you extra support. So one thing to know, right? We have 2 different terms, injury terms that sound very similar. A sprain with a P, right? And then a strain with a T, okay? So if it's with a P, it's a ligament, okay? If it's with a T, it's a muscle or tendon, okay? So I don't want anyone to tell me I strained my ACL. Don't tell me that, okay? You sprained your ACL, Okay, so just something to be aware of. Good to have the right vocabulary there. One of the most common signs of a ligament sprain is you actually hear and feel a pop. Okay, Brett, when you tore your ACL, did you have that audible sensation?
Yeah, it was really loud. It was not a good.
Yeah. Did actually like people next to you hear it too?
Yeah, I was during wrestling practice, and my partner freaked out.
Ugh, yeah, yeah. So yeah, most of the time it's just the patient that can feel it, but sometimes it's loud enough and the people around can hear it too. And it's kind of a stomach churning type of sensation for sure. Yeah, but you don't really get that as much. You can get that with strains, but not as much. But those ligaments, when they pop, there's so much tension on them, and then they pop, and so that's a sprain. Yeah. Okay. Any questions on those or comments on those? Okay. Okay, so let's talk about some other structures that are associated with joints. Okay, so those are the four we're going to talk about here. So let's talk about articular discs. Okay, articular discs, also known as a meniscus, singular, or menisci, plural. Okay, these are fibrocartilage pads, right? We talked about different types of cartilage. One of those was fibrocartilage, right? So these are thick, tough pads, really good for compression and withstanding lots of compressive forces, okay? So we have these in the knee, right? We have a medial and lateral meniscus in the knee. Brad, I'm guessing if you tore your MCL and ACL, you probably also had a medial meniscus tear. Yeah, yeah, not lateral though. Yeah, just medial. Yeah, yeah. It's common to get all three of those in the same shot for sure. So yeah, so that and you see it right here. So here's a tear. That's a superior view of the knee, the top of the tibia there. Seeing those menisci on top. Yeah, so that's that one. The jaw, we talked about that one before. That TMJ syndrome that people can have when their jaw kind of pops or locks. It's because that little articular disc in there can get a little tear in it, or can kind of get stuck between the two bones. We have one of these in what's called the AC joint, the acromioclavicular joint. We'll talk about that more next class with the shoulder. Also the sternoclavicular joint. AC joints out here, sternoclaviculars in here. We'll talk about those more. And then we also have one in our wrist called the distal radial ulnar joint. Those are just some examples. There's more than that in the body too. Okay, so the functions of these discs, number one would be to deepen the joint. Okay, there's two others that I didn't mention in that list that are important for deepening joints. They're both called labrums. There's a labrum in the hip and there's a labrum in the shoulder. Okay, any labral tears out there? And overhead athletes, volleyball players. Brett did it too. Sorry, Brett. Brett said everything. Yeah, Ryland's got one too. Okay, yeah. So super common for throwers, overhead athletes, swimmers, those types of sports for sure. Yeah, so deepen the joint. So we need a lot of help in the shoulder to deepen that joint. So the shoulder and the labrum is very important for that. The hip, it also stabilizes as well. Okay, also provides some shock absorption, and obviously just overall increases stability of the joint. Okay, so the tear symptoms of this would be, again, popping, but more like popping when you're using it. Okay, two P's. Clicking. The other one would be locking. Okay, if you feel like your joint just kind of locks up and you have to kind of push it through and it hurts, it could be a sign of some cartilage actually just gets stuck between those bones, and then you have to kind of pop it through. Okay, so locking, popping, catching, clicking, those are all signs of these meniscus type injuries. All right, questions on that? Everybody's moving their joints around now, catching that little click and pop. But yeah, it's different when you just have a little bit of a pop versus it actually catches and kind of locks. But yeah. Okay, so some other structures we have around joints are, one's called a bursa or bursae for plural. This is really a little sac full of synovial fluid. Using that synovial fluid. Yeah, and so, hold on one sec. Can you guys still hear me all right? Okay, for some reason my AirPods turned on even though I'm not wearing them. I'm glad you can still hear me. Okay, All right, so yeah, they contain synovial fluid. They're found near places that need some help cutting down on friction. So for example, there's one here right on your kneecap, because that's your skin of your knee slides back and forth over your patella, and that little bursa helps it from not getting the bone and the skin inflamed. There we also have them on the other side between our patella and our femur, lots of places that are likely to have high friction, okay? So their function is to reduce friction. So you can get something called bursitis, which we'll talk about, where that bursa just gets super inflamed and it becomes this kind of like jiggly sack of fluid hanging off of your joint. And it's real common to get one on the elbow. I'll show you a picture of one a little later. Here it is. Yeah. So this is what bursitis of the elbow looks like. And if you touch that, it would just kind of jiggle around. It wouldn't be hard at all. It'd just be like a fluid-filled sack. Not really a whole lot you can do for them except to just kind of let them heal up. But if they're just really getting in the way, then you can, a doctor can drain them for you. You can stick the needle in there and just pull the fluid out, and it'll come back. But that might help somebody get through a game or a match or something. And it'll probably fill back up throughout the game though. Okay, another structure we have around joints and outside of joints is called a tendon sheath. Okay, and that tendon sheath is really just like a big bursa, but it's wrapped around tendons. Okay, and you can see a bunch of these here, right? So all these tendon sheaths, we tend to have them in places that are really packed with a bunch of tendons and other tissues. Okay, so we have them in our ankle, and our wrist, and our hand. Okay, so the functions again would be to help decrease friction, and then help for just allowing those tendons to slide smoothly around corners, around places that are tight, compacted. Okay, so it's kind of it's very similar to those bursas, but it's kind of wrapped around a tendon instead of just in a high friction spot. So for example, your fibularis longus muscle is right here. That literally just kind of slings around your lateral malleolus there, and it pulls super tight. Right? And so if you didn't have something there to kind of cut down on the friction between that tendon and the lateral malleolus, you would eventually fray that tendon and the tendon would snap, right? So it helps it to not destroy your tendon. Okay. All right, and another structure associated with joints is called a fat pad. This is really fatty tissue. It's adipose tissue, and is found between a couple different places. So between the fibrous capsule and the synovial membrane, also between the fibrous capsule and the bone. Okay, functions of this are mainly for cushion, so to absorb shock, to provide some cushion for impact from the outside or from places where the bones might come together and kind of smash each other. So a pinched fat pad can be a pretty painful injury in the knee, somewhat of a common injury in the knee, where your patella comes down right here and pinches your fat pad against your tibia, and it inflames it, and it makes it really, really painful and kind of hard to move your knee.
Wait, Dr. Sawyer?
Yeah.
Is that what tendonitis is then?
No, tendonitis would be more on the previous one where we were talking about those tendon sheaths. So tendonitis specifically means inflammation of the tendon. But a lot of times when somebody says you have tendonitis, it might actually be what's called tenosynovitis, which is more inflammation of that tendon sheath. So that's more specific to tendons and tendon sheaths when we talk about tendonitis.
Okay. Thank you.
Yeah. What other questions we got on this?
I actually might have had a question. Sorry to interrupt. Is this localized like pain right in the middle of the knee? Deep pain?
Yeah, not necessarily right. Yeah, it's not deep. This is typically a little bit more superficial, but it would be typically kind of right distal to the kneecap, distal to the patella. That's kind of the most common spot. And a lot of times you can feel it if you kind of like right down below your kneecap, you can feel your patellar tendon where it goes down. But then if you kind of reach around that patellar tendon on both sides, that's kind of where the fat pad is, and you kind of squeeze in there, kind of up underneath your tendon almost. That's the most common one that you can kind of flare up.
Oh, okay. Thank you.
Yeah. One bummer about being virtual. Once we start doing all this joint stuff, I always get students coming up after class wanting me to evaluate injuries, but we won't be able to do that this semester, unfortunately. So, yeah. Okay. Other questions on that? All right. Okay, so and I've been mentioning most of these joint injuries along the way, okay? But let's just review them here. So a sprain, that's a tearing of ligaments, okay? Ankle and knee are most common for sure. This is what's known as an acute injury, okay? And so the difference between a chronic and an acute injury means there was just one thing that happened and the injury happened right there, okay? Chronic injuries are more like, I've been running for the past 2 weeks, 5 days a week, and now my Achilles tendon is kind of sore, right? Or my Achilles tendon is kind of flaring up. It's like small amounts of tension or small amounts of challenge to some part of your body, and eventually builds up some inflammation, and that's more of a chronic injury. Okay, so acute versus chronic injury. So sprains are typically acute injuries. Bursitis, I kind of mentioned, we already talked about this one. Inflamed bursa, hip, shoulder, elbow. This is definitely a chronic overuse injury, but it can also be acute too. If you just get slammed on the end of your elbow, that can flare up the bursa too, but it's more commonly a chronic injury. Okay, cartilage tears. So the labrums I talked about, the menisci we talked about. This is more commonly acute, but it can also be chronic. Most of the time, these need to be surgically removed or surgically kind of cleaned up so that we can, so that you can not get that popping and locking in there anymore. And a lot of times this will cut down on the overall wear and tear in your joint. If you get a little chunk of it, a lot of times you'll have a chunk of this floating around inside your joint, and that can get removed to help clean this up. And that's typically just called a meniscectomy. Okay, and so a meniscus, meniscectomy, ectomy just means removing something from your body. Meniscus, obviously, meniscus, so removing part of your meniscus. And that's a super common surgery. Most people are back to full participation within 2 weeks after a meniscectomy. But if you can repair it, it's much better, okay? But then it's a real long recovery, okay? If you can repair it and it actually heals up, it's better for your long-term joint health, but it takes much, much longer to recover, and you're most likely out for the whole season if you're an athlete, but it might be worth it in the long run to avoid arthritis. So it's a cartilage tear, tendinitis, like we were just talking about. This is inflammation of the tendon or the tendon sheath. This is definitely a chronic overuse injury. Okay, and we can see this here. This is kind of what I was talking about. When the tendon sheath actually gets inflamed, it kind of pinches on the tendon, and when you move your joint around, you kind of feel this crunching back and forth as that tendon tries to slide through that sheath that's now too tight for it. It kind of like this crunching, kind of crackling sound in your joint. Not too fun of a sound. All right, questions about these? Okay. All right, so arthritis, I mentioned this one before. So there's two main types of arthritis: osteoarthritis and rheumatoid arthritis, okay? And there's another one as well, the gouty arthritis that we'll talk about. Osteoarthritis, this is degeneration of the hyaline cartilage, okay? Most common type of arthritis for sure. Synovial fluid is also dried up, and this doesn't heal well at all, okay? Once you're moving towards osteoarthritis, there's really not a whole lot that we can do for it, except for try to just strengthen the joint around it, keep you moving some so you can keep producing synovial fluid, but that damage to the hyaline cartilage itself just doesn't heal well, okay? One of the surgeries that has been tried for that is called microfracture surgery, where they take this little tiny needle, or not little tiny drill bit, and they go in there and drill a bunch of holes in the end of your cartilage down into the joint, and then that gets some blood into the cartilage, hopefully some stem cells that can help us produce more cartilage, but there's mixed results with that one, and obviously it doesn't sound good to drill a bunch of holes in your bone, but it's a risky one, but some people can have success with that. So it's osteoarthritis. And so most people that have like a hip replacement or knee replacement, it's because they had such severe osteoarthritis that they just needed to remove the end of that bone and put something synthetic on there. Okay, rheumatoid arthritis is an autoimmune disorder where your immune cells actually attack the hyaline cartilage in your joints, okay, and just destroy that hyaline cartilage. And that also causes inflammation of the synovial membrane and thickens it. And you'll see these kind of deformed looking knuckles in people with advanced rheumatoid arthritis. And there's really no cure for this as well. There's treatments, where we try to suppress the immune system from destroying it, but there's really no known cure for it at this point. And then gout or gouty arthritis is a different thing altogether. It's due to excess uric acid in your blood. Okay, this is supposed to be one of the things that's secreted in your urine, but people that have kidney failure, that's one of the most common causes of this. People that the kidneys aren't working properly, they're not able to get rid of that uric acid, and it builds up in the blood. And for some reason, it just kind of it settles into joints. And when it settles into joints, it literally creates these like kind of crystallized chunks inside the joint, and can almost sometimes fuse joints together. It's extremely painful condition. And yeah, so it just kind of results in this chronic inflammation in the joints. Okay, any questions about any of those injuries or arthritis? Okay. All right, so yeah, let's go ahead and do this one, and I will let you do this or put in multiple answers here. So go ahead and you can put in all of the ones here that that would help hold joints together. So put all those letters in, just write one right after another. What things are actually helping to hold the two bones together in a joint? All right, give you about 20 more seconds. We'll just put all those letters in you think would help us hold bones together, hold joints together, and hit submit or send, whatever it is. Okay, about 5 more seconds. Good, I think we got just about everybody. See what you said. Okay. So pretty big mix of all kinds of stuff here. Nothing really standing out because everything is counted as separately. So yeah, so let's walk through it. So ligaments, that is their primary function, is to span the gap between two bones and pull them together. So definitely ligaments help hold joints together. Okay. Tendons' job is to connect a muscle to a bone. Okay. So it's not necessarily there to hold the joint together, but they do, right? If you have a tendon that crosses over a joint, that tendon's connected to a muscle, and you contract that muscle, what's going to happen to those two bones? It's going to pull them together, right? If you have a muscle coming over this way, it's going to pull that bone towards the other one as it pulls on it, right? So tendons are definitely a part of that. And if tendons are a part of it, muscles have to be a part of it because that's what's pulling on the tendons. Okay, cartilage. So we got hyaline cartilage, we got the fibrocartilage. That doesn't necessarily span, that never spans the joint, right? It doesn't go from one side to the other, but definitely we know that menisces and things like that, and labrums, those deepen the socket. So they help stabilize for sure, but they don't actually go from bone to bone and hold them together, right? But they definitely help stabilize the joint. Okay, and then fibrous joint capsules for sure. This surrounds both bones, holds them together. So definitely an important part of holding joints together. Okay, any questions on that one? Okay, so we're gonna finish up today with talking about joint stability and different things that contribute to that. Okay, and there's really 4 main categories of things that we're gonna talk about. I'll walk us through the first couple, and then if we have time, I'll send you into your breakout rooms to try to kind of think about the last joint and what things might help to hold it together. Okay, so the 4 factors to talk about with joint stability are: number 1, the structure of the joint. Okay, and that's really the bones, right? How deep is the socket? If you're talking about a ball and socket joint, how much contact do we have between the two bones? Okay, so the structure, that's number 1 factor we need to think about. Number 2 is the muscles around it. Okay, so we have 2 different ways that muscles help stabilize joints. The first one is the ones that are directly crossing the joint. okay? So think about your quads, your quadriceps, and they go down and attach to your patella, and then they cross over your knee joint and attach to your tibia, right? Those are direct stabilizers of your knee, okay? But then you have something called an indirect stabilizer, and an indirect stabilizer is something that a muscle that doesn't cross over the knee or cross over the joint that we're talking about, but it does help stabilize the joint nonetheless, okay? And I'll give you one example of that by standing back a little bit. I don't know how much you'll be able to see it, but I'll give it a shot. So with my knee here, I've got shorts on, which I always do these days, so you just don't know if we can see that. But with my knee here, if I was gonna do can you guys see my right knee when I stand up? Yeah, cool. So if I was gonna do just a single leg squat, like this is gonna go down like that, right? And I think I'll move it down just a little bit more so you can see. What I don't want my knee to do, I don't want it to bow in like that, right? If it bows in like that, that puts a lot of stress on my ACL, on my MCL, okay? So what actually keeps me from doing that is not so much my quads and my hamstrings, the ones that cross the joint, but more so it's my hip muscles, right? Because my hip muscles will keep my knee straight as they go down, okay? So my hip muscles are very important for keeping my patella right over my toes as I go down, okay? I don't want that to happen, right? Because when that happens, that's what puts you at risk of tearing your ACL. Okay, so an indirect stabilizer of the knee, one of the most important ones is called your gluteus medius muscle, because your gluteus medius muscle does exactly that. It abducts or abducts your hip and keeps your patella straight over your toes as you're going down into a single leg squat like that. So that's an example of an indirect stabilizer of the knee joint. Okay, so we got joint structure, we got muscles, and then ligaments, obviously, depending on the joint. Some joints have a lot of strong ligaments, some have kind of weak ligaments, and they can provide various levels of stability. And then the cartilage, does the joint we're talking about, does it have a meniscus, does it not? How helpful is that meniscus? How unhelpful is it? Okay, so we'll look at all these 4 factors in the 3 joints that we talk about, the knee, the hip, and the shoulder. Okay, any questions about these contributing factors before we jump into a couple joint examples?
So did you give an example for the direct muscles?
Yeah, so the direct would be like that, like the quadriceps going over your knee, okay? Or the hamstrings coming over the back of your knee. It's a muscle or tendon that crosses over the joint and stabilizes that specific joint. Okay. All right, so let's start with the hip, okay? So we'll start with the hip. And when we think about the hip, these are just some images of it here. We can look at kind of the bones involved, right? That would be our structural part of it. This one shows us the ligaments up here. This iliofemoral ligament is the strongest ligament in the whole body. It can withstand, I can't remember the number off the top of my head, I have it in Monday's notes, but it can withstand something like 700 pounds of tensile force before it tears, okay? And then the hip has some incredibly large muscles around it too, right? It's got the gluteus maximus, the largest muscle in the body. It's got some strong hip flexors on the other side, lots of muscles in the back, okay? So when we think about the hip, the joint structure of the hip is really a very deep socket, right? It's a ball and socket joint. And that socket is deep and the ball fits in there very well, okay? So the joint structure of the hip, and really what we're doing with this is for each of these categories, for each of these joints, I want you to be able to say, does this give us a lot of stability, or is this kind of not so good of a stabilizing factor for this joint that we're talking about specifically, okay? So this one definitely gives us lots of stability, okay? It's one of the strongest joints as far as the structure goes. Muscles, okay? So there's lots of hip muscles, okay? They're especially posteriorly around the gluteal region, and then there's also quite a few anteriorly and medially. All your adductor muscles cross over it. So lots and lots of direct stabilizers. The indirect stabilizers might include like your back muscles, okay? The position of your back is very important for joint stability of the hip, okay? So there are some back muscles that help stabilize this. So again, overall, we have lots of stability coming from muscles in the hip. Okay, ligaments, I already mentioned, very strong ligaments in the hip, and also lots of ligaments. Okay, and then cartilage, we do have something called a labrum in the hip. It's known as the acetabular labrum. Right, you guys learned the acetabulum in lab. Just probably had it as one of your questions yesterday on the practical. Okay, so there's a labrum that goes around that. It's a thin rim of cartilage that helps to deepen the socket even more. Okay, it was already a deep socket, but this helps to deepen it even more. So again, lots of support from cartilage in the joint, in the hip as well. So the hip is very stable. It's very uncommon to dislocate your hip. If you do it somewhat, it's pretty dangerous because you have large blood vessels going right next to your hip and large nerves, like your sciatic nerve going right next to your hip. When I worked for the Chargers, our team doctor was extremely confident, which a lot of team doctors are, for good or for worse. But he there was a guy, we were playing the Vikings, and there was a guy who dislocated his hip on the field from the Vikings, not from our team. The team doctor for the Vikings didn't want to touch it. He said, "There's no way I'm going to relocate his hip on the field." Our doctor said, "Yeah, I can do it, no problem. I'm not worried about it." It's a very dangerous one to relocate because when you put it back in, if you happen to pinch the femoral artery or the sciatic nerve, they'll most likely lose their leg. Yeah, absolutely. Daniel Bo Jackson was one who dislocated his hip for sure. They had to relocate. I'm pretty sure with him, they relocated his back in the hospital. Yeah, with this one, so our doctor did it right there on the field, popped it right back in, and he felt a lot better afterwards. That's always the thing. If you can get a joint to go back in, you're the hero, right? Because it feels a million times better as soon as it goes back in. But if you mess up, it could be catastrophic for that limb. So that was kind of a wild one. Okay, let's talk about the knee. So the knee, structure of the knee, just the fact that the joint surface of the tibia that we use for the knee is called a plateau is a bad sign, right? A plateau is not something we would think of to put something else onto and hope that it would hold onto it well, right? It's just flat. Right, so it's not a very good socket, right? There's not like a big ball and socket, and then the end of the femur does have some rounded surface to it, which is helpful. Okay, so the structure is not great. We see quite a few ligaments here in the knee, both sides, and the back as well, and then we do have quite a few direct and indirect stabilizers of the knee, like we talked about. So the joint structure is not stable at all. Not a stable joint structure. The muscles of the knee, the direct stabilizers for sure, we're thinking quads, hamstrings, okay? Definitely lots of direct stabilizers. Indirect, gluteus medius in particular, okay, but also other hip muscles. Okay, ligaments, we talked about the ACL, PCL, LCL, MCL. There's lots of other ones too. So so this does provide us lots of support. Okay, the hip really has, or sorry, the knee really has to rely on muscles a lot. Okay, so this one is not so stable for the structure, relies on muscles a lot. For ligaments, there's a lot of ligaments. Okay, there's lots of ligaments in that, and the knee has to rely on those quite a bit. Okay, cartilage, we have the meniscus. Okay, both lateral and medial. And this helps, we'll just say some. Okay, it helps to deepen the socket a little bit, but it's not great. Right? It's not giving us a lot of depth to that joint. Okay. All right, so here's what I'd like you to do. Is the next one gets into the shoulder, okay? And I can go back to that slide in a second, but I just wanted to introduce this here. The shoulder, I'd like you to use this image here to talk about structure, use this image here and maybe what you know to talk about the ligamentous structure. And then we've got some muscles here, right? Both small ones and big ones, okay? Use that, and I'm gonna send you into your breakout groups here to fill in this last part here about how do you think all of this applies to the shoulder, okay? And yeah, I'll put this back here in case you're still writing that. And so I'll put you into your breakout rooms, talk about that, how this applies to the shoulder, and we will wrap up with that, okay? So let me go ahead and send you out. It's always the same people, huh? Sorry about that. I don't know why I can't get it with you guys. 14. All right, guys, looks like everybody's back. I went ahead and just filled in kind of my notes for that, and I'll just run through that real quick. Structural support in the shoulder, terrible, right? This is the worst. We think of this as a golf ball on a tee, right? Big round socket with a tiny little tee, right? Doesn't give us much support, okay? But it gives us a lot of movability, right? We can move it a lot because of that. Ligaments, there are some, but they're very weak, they're very loose. They don't give us a lot of support, okay? Cartilage, we do have the labrum, which helps. It increases our contact area of the joint by 75%, but it's still not enough, but it does help for sure. And then muscular support, the shoulder relies heavily on muscular support, right? So we're talking about mainly direct stabilizers. So that's our rotator cuff muscles, our deltoids, our pectoralis major muscle, right? And then our latissimus dorsi muscle. Those are all big muscles that, or at least the deltoids, the pecs, and the lats are big muscles that directly support it. Rotator cuff is our small muscles that directly support it. And then we do have some indirect muscles too. The indirects would be the scapular muscles. And we'll get into specifics on the names of those later, but in order to move your shoulder, you got to move your scapula too, right? And so you got to be able to do that in the right way in conjunction with moving your shoulder to have a stable shoulder. Okay, so the shoulder has to rely a lot on that muscular support. All right, guys, we went over, but thanks for hanging with me.